right, we'll go ahead and get started tonight. Thank you everybody for joining us. My name is Rishi Batra. I'm one of the colorectal surgery fellows at Mayo Clinic and part of the Colorectal Virtual Education Series Leadership Committee. Tonight we have a very anticipated talk tonight by Dr. Henke. Dr. Lauren Henke is an assistant professor of radiation oncology at Washington University in St. Louis. She graduated medical school from WashU in 2014 and then went on to complete radiation oncology residency at Washington University as well. During her time in residency, she also completed a Master of Science in Clinical Investigation and Study Design at WashU as well. She then went on to join the staff as a radiation oncology faculty in 2019. Tonight, she's going to talk to us about radiation oncology and rectal cancer, total neoadjuvant short course, and as well as non-operative management of rectal cancer. Thank you again for joining us tonight.
Absolutely. Happy to be here. I will throw out the caveat that I have a 10-week-old golden retriever puppy and 2 rescue cats that may try to make a cameo. I apologize if they do. Hopefully they're contained. I'll go ahead and share my slide deck. Hopefully you should be able to see that. Can I get a thumbs up? Awesome. Okay. So as you just heard, tonight we're going to talk about short course, total neoadjuvant, and non-operative management of rectal cancer. So this is a series of topics that are all, potentially on their own a full discussion, but I think that they're easy to group together in the sense of they flow in terms of the overall rationale and how they've evolved in the field. So with that, I don't have any disclosures related to this talk. And my objectives tonight are to give you first a really quick refresher of staging and anatomy, at least from the radiation oncologist's perspective, just so that we're all on the same page. And then from there, we'll talk about the role of radiation in rectal cancer treatment, and specifically the use of short course radiation therapy. From there, that will flow into how and why total neoadjuvant therapy overall has arrived and how I think it's going to stay. And then from there, the further evolution into non-operative management. So this should hopefully be a nice refresher for everybody and not anything new, but in terms of what we're discussing anatomically, we're talking about the rectum, pelvis. This is the at-risk nodal drainage. All of these things are things that I'm considering when I'm thinking about the anatomy of a rectal cancer patient. So I'm not only worried about where their gross tumor is, but I'm worried about covering micrometastatic disease and nodal regions at risk. So this is just here for your reference. In terms of workup for rectal cancer, as we all know, we want to make sure we have a complete colonoscopy with biopsy confirmation. That's usually how these patients are coming into us, or perhaps our first step in diagnosing them. They are going to need laboratory workup. CEA is a nice tumor marker in many patients. And at some point, they are going to get a rigid proctoscopy, often by colorectal surgery, to confirm the distance of a primary tumor from the verge and really determine if this is rectal versus sigmoid. Along the way, they'll get CT of the chest and abdomen, sometimes also the pelvis, just by default. And then a pelvic MRI is really the mainstay of local regional staging. PET CT, as you probably know, is not typically indicated unless there's a remaining clinical question that just isn't answered by things that you've done so far. So in terms of staging locally, pelvic MRI is the gold standard for local extent of disease. It helps you evaluate the primary, depth of invasion, relationship to key structures like the mesorectal fascia, of course, and then also adjacent organ involvement. And then it's the mainstay of evaluating nodal disease as well. So when we think about rectal cancer staging with MRI, it's quite good, although not perfect. It's got about 75 to 80%, 85% accuracy in terms of T staging. Also reasonable accuracy in mesorectal nodal staging. Unlike the prior gold standard of ultrasound, it does allow you to assess IMA and pelvic nodes as well. And obviously, as you can see here with the annotated image, nicely shows the relevant anatomy that we're worrying about, like the mesorectal fascia you can see with the black arrowheads, determining tumor staging, if this is T3 through the muscularis propria, which is the 2 white arrowheads, the mesorectal fat, and evaluating all the lymph nodes. So it really shows that quite clearly here. So tumor staging, of course, depth of invasion, nodal staging, also pretty straightforward, count the nodes. So from my perspective, what do I mainly care about? I'm going to care if this patient is T3. Like you can see in the figure, there is clear tumor penetration through the muscularis propria there, the red arrows, that kind of reactive involvement into the fat. And then also I'm going to care if they're N1 or higher. And that is because both of those things become indications for radiation in the setting of rectal cancer. So in terms of lymph nodes, just leaving these here for your reference. Lymph node staging by MRI is sometimes challenging. You're really going to lean on your radiologist here. But things that you're looking for are round or heterogeneous or indistinct borders on nodes, as well as size. Some references here for you. Table 3 in the first reference is really helpful, and the others are kind of the mainstays. I, as a radiation oncologist, and probably you also as a colorectal surgery fellow, are going to be looking at whether or not there are nodes also outside of the circumferential resection margin. In particular, there's some data out of Japan indicating that nodes that have a larger than 7 millimeter cross-sectional diameter have a higher risk of failure if they're not intervened upon directly, whether that's a lateral node dissection or, in the case of what we do here at WashU, boosting those nodes to a more definitive higher radiation dose. So when to radiate, I'm just moving a header out of the way here for myself. Okay, when to radiate. So T3 or more, or node positive disease, they're getting radiation. So hopefully that was kind of nice, quick catch up for everybody and a good sense of what I'm looking at as these patients come into our clinic. So then from the perspective of radiation, starting way back with some old data, first up is the Swedish trial. So this was looking at what is really the role of radiation in these patients, at least initially. It's a study of surgery alone versus preoperative radiation using short course actually ahead of surgery. And this study, which specifically did not use a TME surgery, because again, this is an older trial, actually showed an overall survival advantage to adding radiation preoperatively. Local, regional, or local recurrence was also drastically lower with the addition of preoperative radiation in this study. Like I said, though, this predated the adoption of TME, and the local recurrence rate in the surgery alone group is quite high. So what can we conclude from this a little bit older study is that if you're not doing a TME surgery, which hopefully you all are and will have adequate training to do so, radiation will then be able to make up for that to a degree. So I can help you clean up if there's not a TME. That said, another interesting thing that leads out of this, and a question I often get asked by our residents in training, is how did we really establish T3 and N1, just as kind of a side note, as needing radiation? So that question actually dates back really to pretty old data when we're thinking about like Duke staging. So this is local recurrence by Duke stage. So you have stage A, B, C here broken out in that same Swedish trial. So if you need a quick reminder, Duke's B is tumor invasion through the bowel wall, so T3, and Duke C is if there's positive nodal involvement. So as you can see here, there is actually some benefit to local control in Duke stage A, at least again in this non-TME era, but that local failure rate in the absence of radiation is actually still really low, about 10%. So when we think about when we add in radiation as kind of an adjuvant or a neoadjuvant helper, a lot of times my criteria is looking for a benefit, a potential benefit of 10% or so. So if the failure rate is already at or below 10%, there's not a whole lot I might necessarily add. So again, so low failure rate in that setting, don't necessarily need radiation. So moving on now in the TME era, what is the role of radiation in that setting? So the Dutch trial provides a nice answer to that. It's TME alone versus, again, short course radiation preoperatively. And if a patient got surgery alone, they did actually in this study end up getting post-op radiation as a requirement if surgical margins were close or positive. So here, in the setting of a TME, no difference in overall survival. However, there is a big improvement in local recurrence rate, which is significantly decreased by radiation by about half. So the role of me in the treatment of rectal cancer, at least historically, and we'll get into some caveats obviously tonight, the role of radiation is to reduce local recurrence, not to improve overall survival. And again, I'm going to be offering that in patients who are T3 or node positive, at least traditionally. Also going to hopefully, in having some treatment response, help to sterilize and downstage nodes, help you out with resection, making that a little bit easier on you. There's also, as a caveat, lower morbidity with preoperative radiation as opposed to post-op RT. So that is the next question. Why not postoperative radiation? It seems kind of nice. We talked about how pelvic MRI staging isn't perfect. You know, with surgery, you'll get perfect path information. Well, it turns out that when you give patients postoperative radiation as opposed to neoadjuvant radiation, as in the German trial, you're going to see not only an increase in local recurrence rate using post-op, but also a really substantial increase in toxicity. So that will be with both acute and late toxicity increases. And then also in patients, although it's not circled in red here, in patients who were perceived to require an APR upfront, about half of those patients did not end up needing an APR using preoperative radiation. So in other words, they were downstage. So there's better sphincter sparing in patients who are at least initially sort of seeming destined for APR. So the longstanding NCCN recommendation as a result has been to do neoadjuvant long course radiation, chemoradiation, which is 45 gray to the pelvis with a 5 gray tumor boost with typically concurrent capecitabine or continuous infusion 5-FU, a break, usually about 6 weeks, resection, then another break, and then as soon as they're medically able, typically adjuvant FOLFOX for 4 to 6 months. And that information or that data for adjuvant chemotherapy is largely extrapolated actually from colon cancer. We'll touch on some of that a little bit later as well. But just of note here, there's a lot of delays that we're seeing built in here. We have a delay after radiation, a delay after surgery for recovery. And we also know from some meta-analysis data that there is apparently a decrease in overall survival with chemo delays after surgery. So all of that is a very long course of treatment, at least 4 months in sort of an ideal setting, usually a lot longer than that. So what about at WashU? What do we do? So we do preoperative radiation, and hopefully this is everywhere after the German study. But we also do short course radiation, which is 25 gray in 5 fractions. Usually we do that Monday through Friday in 1 continuous week. And that said, many United States centers still use long course, which is 28 days of treatment with concurrent 5-FU or capecitabine. And I want to be clear that this is also overall acceptable, although it's very clearly logistically more challenging for patients. I think that goes without saying. So if that's been the NCCN recommendation is to do long course, is short course okay? That's a question we often get. Yes, the answer is yes. So there have been a couple of good randomized studies on this, but probably the cleanest of them is the Trans-Tasman trial. So this study looked precisely at giving neoadjuvant short course radiation versus neoadjuvant long course chemoradiation. And they did surgery at 4 to 6 weeks, and 5-year overall survival was not different. So not a difference in your primary oncologic outcome. There's also not a difference in local regional failure or recurrence-free survival, as you can see here from these Kaplan-Meier curves. Importantly, late toxicity was also not different. That is something that I think there's historically been this perception that short course radiation might result in worsened late toxicity, but that has not borne out in more than 1 randomized trial. Then there's another question that evolves when you're talking about short course. So in the studies that we've touched on so far, Dutch, Swedish, Trans-Tasman, in the short course setting, generically, people have operated actually in history within 1 week immediately after finishing radiation. So if they finish radiation on Friday, you'll operate probably sometime the next week in that subsequent Monday through Friday. However, now the generic answer should actually really be about 4 to 8 weeks after radiation is done. And that's based on more recent data from the Stockholm 3 trial. That was a nice trial of short course to surgery within a week versus short course with delay, waiting 4 to 8 weeks, then surgery, or long course radiation, again with delay of 4 to 8 weeks and then surgery. What this study found is that all 3 of these arms were actually oncologically equivalent. And importantly, in terms of timing surgery after a short course, it also found that there was about a 10% reduction in the rate of post-op complications if you did delayed surgery after short course. Took it from about 50% to about 40%. So if you're going to do short course, you ideally want to wait a delay after finishing radiation, which really shouldn't be that foreign of a concept, given that we usually have that similar delay after long course. So I want to touch a little bit on why then is there some reluctance in doing short course radiation in the United States. It's 5 days long. It's much more convenient to the patient. It's apparently oncologically equivalent. What's the holdup? So historically, I just mentioned how there was some difference in timing of surgery after short course versus long course. And I don't know if you can hear this, but there's a thunderstorm outside here right now. So sorry for any background noise in advance. But anyway, so with this historically different timing in surgery for short course versus long course, short course, again, historically being immediately, and long course usually having a delay after chemoradiation, there was a higher pathologic complete response rate that was seen with long course chemoradiation delay compared with short course and immediate surgery. And there are several studies that describe this, but one nice one is the EORTC study, where that path complete response rate was about 15% in long course delay versus 5% with short course and immediate surgery. So that has led some patterns of practice to be long course because there is a better response. There's easier operation for the surgeon because of that response. And we also know that there is correlation of long-term outcomes, namely disease-free survival, overall survival, based on path CR rates. So it was felt that with a lesser path CR rate, short course potentially not only made surgery harder, but maybe didn't truly have as good of outcomes. So Stockholm 3 actually gives us some nice answers there too. In a separate side publication there was analysis of pathologic complete response rates in all those different lines of therapy in Stockholm 3. So short course delay, long course. And sure enough, path CR rate does correlate with long-term outcomes. That appears accurate. So if you look here, you see that we have the path CR patients versus those without a path CR, and the likelihood of being alive is better if you have a path CR. Similarly, the likelihood of failure is less recurrence if you have a path CR. However, what Stockholm 3 also showed is actually that with similar delay to surgery after short course, 4 to 6 weeks, the path CR rate after short course is not worse. In fact, it was similar to historic long course chemoradiation controls at about 12%. And if you actually look at the study arms, although this is the caveat being here, this is long course without chemo here, it actually performed the best, at least in Stockholm 3. So similar to long course in terms of path CR. So that's not a great reason anymore. So again, why that reluctance? Again, historically, there's been a perception of worsened late toxicity with short course radiation overall, and worsened acute toxicity with short course with delay. However, both Polish 2 and Trans-Tasman show no worsened late toxicity in comparison directly of short course with long course chemo-RT. And Stockholm 3 also showed no difference in acute toxicity between long course RT and short course RT with delay. So maybe it's mainly that old habits die hard. And then if we're going to be really cynical, and hopefully this is not the main driver here, there is some difference in reimbursement payment models that could potentially play a role as well. Okay, so what should you expect with short course radiation other than equivalent oncologic outcomes? Absolutely, these patients will get proctitis. So radiation side effects are unique in that they're a little bit delayed. Typically, in terms of short course, patients actually won't notice side effects during the week of treatment. They will feel great. They're going to have basically no idea I'm radiating them. It's fantastic. But then by the following week, they will absolutely know that I've radiated them. I tell people jokingly that they'll shake their fists at me from their toilet. They are going to have substantial proctitis, and that includes tenesmus, so multiple trips to the bathroom, some of them fruitful, some of them not. I would just say that if a patient has some near obstructing symptoms already, something to really keep an eye on, and they might want to be on a liquid mainly diet. Proctitis also happens with long course radiation. It just doesn't happen suddenly. It happens in a slow buildup over the course of treatment. With diarrhea, also cramping belly pain, sometimes some urinary symptoms, although those are less likely. And typically, there is not actually a radiation-specific skin reaction with short course or with rectal radiation in general, although you can get skin irritation perianally or even fissures sometimes from diarrhea. So every once in a while, I will send a patient back to colorectal after radiation who's got a lot of new onset pain with bowel movements for concern for fissure. So something to keep a lookout for as well. And every once in a while, they'll have something like a sciatica flare, but that is typically easily resolved with the Medrol dose pack. Late changes, even if we ultimately avoid a surgery, which we'll talk about, there are some mild to chronic changes in bowel habits, urinary frequency, and then in women, always important to remember that pelvic radiation can cause vaginal stenosis, although it is largely preventable with use of vaginal dilator after treatment. Okay, so hopefully you have a sense now of the role of radiation and that using short course radiation is not only okay, but also potentially very convenient and straightforward for your patients. So with that, let's talk then about how in that context, total neoadjuvant radiation has arrived to the scene. So that also is going to require that we talk briefly, at least, about chemotherapy, which is not a hat that I wear and probably not a hat that you wear, but something that we need to be at least loosely aware of. So we know, stepping back historically in the medical oncology data, that in patients with rectal cancer who had, quote, deeply invasive or lymph node positive disease in the classic Crook New England paper, the addition of chemotherapy to radiation in those patients resulted in improvements in recurrence-free survival as well as overall survival, also reduced local recurrence rates. Stepping back some more, we also found that there is an importance to the style of delivery of chemotherapy. So we know that continuous infusion is better than bolus during at least post-op RT. Again, we don't use post-op RT, but we can extrapolate from this that there is a benefit to adding in chemo in terms of control and potentially survival outcomes. Then we extrapolate a little bit more from colon cancer because there's not actually a whole lot of great direct data for chemo, at least in the randomized sense, for rectal cancer. So we know from really classic studies, like the intergroup trial, that adjuvant chemotherapy improves overall survival for stage 2 and 3 colon cancer. And then if we add oxaliplatin to that from the MOSAIC study, we further improve disease-free survival and overall survival rates. So with that in mind, chemotherapy has a benefit to our patients, and that has been the kind of accepted truth, although again, the randomized data aren't perfectly there for rectal cancer specifically. So why then is total neoadjuvant treatment so appealing if we could just give adjuvant? So first of all, we already said that now you're going to be waiting about 6 weeks for surgery anyways, after radiation. And that's for both allowing radiation response as well as toxicity reduction. During that time, you're going to have no micrometastatic disease coverage. And we also know that the clinical complete response and path complete response rate in the pelvis are only 10 to 20%. So even with adjuvant chemo, disease recurrence also is 2 times higher outside of than inside of the pelvis. So we need to be worried about micrometastatic disease, and we need to be worried about systemic treatment. That is where our patients fail, is systemically. We're really good at controlling pelvic disease at this point. So adjuvant chemotherapy is a challenge. Multiple studies show that compliance with adjuvant chemotherapy is poor. Postoperative complications further add to lack of receipt of intended chemotherapy, and only about 3/4 of people at best actually start and or complete adjuvant chemotherapy as they were intended to. So with that in mind, rather than trying to give people a challenging treatment course of chemotherapy while they're also recovering from a potentially very large surgery, we can move it ahead of surgery. And so total neoadjuvant therapy is exactly that. It's giving all of the radiation and all the chemotherapy before surgery. And that can take several different forms, but that's the key principle that defines TNT. So at WashU, we've been dabbling in this for a while. Our initial experience was a phase 2 non-randomized institutional study that accrued patients between 2009 and 2012. The look at this study was the response rate. And what we found that when we added, and this was again with short course, added chemotherapy after short course ahead of surgery, we had a large increase, at least from historic comparison, in the path CR rate, so 28%, which is quite good. Also had a substantial, at least partial downstaging of the primary, about 3/4 versus less than half. We also found that there was similar toxicity. Of course, in moving chemo preoperatively, you're going to have more preoperative hematologic consequences. However, in terms of GI toxicities, really the same for pre versus post-op chemo delivery. And late toxicities were very similar. So along those same lines, the European model was similarly evolving. And so with that, the Rapido phase 3 randomized clinical trial that I hope that you have all at least heard of, evolved. And WashU was actually the only participating American site in this study. The rest of the participating sites were in Europe. And it was published this last year, of course, presented at ASCO the year before. And what the study was giving the standard of care, which was in the United States and in much of Europe, RT with concurrent chemotherapy for long course, followed by a break, then surgery, then a break, and then either 12 cycles of FOLFOX or 8 cycles of CAPOX. And then the experimental arm was to instead do short course radiation, followed by a short break, then followed by chemotherapy initiation. And that gap is about a 2-week gap, and we stick with that now, that break between radiation and chemo. Then another short break before surgical resection. And the primary endpoint of this trial was disease-related treatment failure. That looks at local regional recurrence, progression on treatment, R2 resection, distant mets, new primary colorectal cancer, and treatment-related death. The eligibility in the study were patients that had a tumor less than 16 cm from the verge. And then really importantly, these were high-risk patients. So they had to have at least one high-risk feature, if not more, on pelvic MRI. So they had to be T4A or B disease, had to have at least 4 lymph nodes or 4 lymph nodes involved. These are all and ors, I have to say. Extramural vascular invasion, involvement of the mesorectal fascia, or one of those enlarged lateral lymph nodes. So really high-risk patients. And so what do they find? First of all, treatment tolerance was really similar. So we're not making people have a worse time by doing total neoadjuvant. Diarrhea, proctitis, GI symptoms potentially related to radiation were essentially identical. And I'm pointing that out because if you remember from the slide we just looked at, the course of treatment here was long course chemoradiation, surgery, followed by chemo versus short course then chemo. So there were concerns that, oh, with short course added in, we're going to have worse toxicity. And the answer was no, we didn't. They were essentially identical. Disease outcomes, however, were distinct. And that was in particular the primary endpoint. So disease-related treatment failure was reduced by about 7% in the experimental arm compared to standard of care. You can see that here. And that was within that a reduction in distant metastases by almost the same amount, 7%. And importantly, no difference in local failure. So breaking out those other two outcomes that I just mentioned. So this is the distant metastasis reduction that you see by doing the chemotherapy up ahead of surgery. And that local regional failure, again, no different. And highlighting that because again, although the radiation question here, the radiation difference here was actually not the question. The real question was moving chemo to the front. It is still important to mention that there's no difference in local regional failure between these two sides. The path CR rate was fantastic, almost 28%. And that was compared with 14% in the standard arm, which is fairly typical if you look back at historic data as well. So what are the criticisms and questions behind Rapido? So in the standard arm, adjuvant chemotherapy, as is often the practice in Europe, was optional. And again, that's because those chemo data aren't really perfect for rectal cancer. That being said, on subset analysis, lack of adjuvant chemo as an option, or lack of adjuvant chemo did not actually seem to affect the probability of a patient having a disease-related treatment failure in this study. It's also potentially a question or criticism that this is a high-risk cohort by intent. So do we then extrapolate total neoadjuvant and maybe short course to lower risk patients too? We don't really have explicit instructions here. The good news is that the French are a little bit helpful in that regard. So in Prodige 23, we get a few of those answers, or at least fill in some gaps. So this trial was total neoadjuvant with 6 cycles of modified FOLFIRINOX, so a little different chemotherapy, at least for 6 of the 12 cycles. Then long course chemoradiation, followed by surgery and more chemo, or preoperative chemoradiation, then surgery, then adjuvant chemo in the standard fashion. So this study did include T3 patients, and it also included N0 patients. Appropriately, they were stratified across the arms, of course, but we're seeing those lower risk patients that weren't in Rapido, so that's nice. And what did we find? So the primary endpoint, disease-free survival, was improved with the addition of neoadjuvant, or excuse me, with the shuffling of chemotherapy up ahead of surgery for at least half of the chemotherapy that was delivered. Overall survival was not significantly improved, although if you are a believer in trends, there is a trend for it. I hate even saying that, but it's there. Adjuvant chemotherapy, nicely, was mandated in both arms. So unlike Rapido, which is criticized because adjuvant chemo wasn't mandated in the standard of care arm, here it is. It was mandated for 12 cycles total in both arms. And both arms had similar chemotherapy compliance. So that truly seems to favor that moving neoadjuvant chemotherapy up ahead of surgery really does reduce the risk of distant metastases. And that is exactly what this also showed, looking specifically at distant metastases, is that there is that reduction in disease, or that improvement in disease-free survival that we see here as well, is again being driven by that reduction in distant metastases. So also important to surgeons, although you should care about distant metastases as well. There is no change here in the postoperative morbidity or the postoperative length of stay across these two arms. So again, the pass CR rate was improved compared to the standard arm, again to about 28%. Remember, Rapido was 27, 28%. So with that in mind, total neoadjuvant, I think, has arrived to stay. It improves patients' DFS, distant metastasis-free survival, and in high-risk patients appears to improve overall survival. And those are all hugely important goals in rectal cancer treatment. So what then about further evolving into non-operative management. So in total neoadjuvant therapy, I think that you can really actually better see this origin of non-operative management. So fundamentally, non-operative management has come about because we observe a pathologic complete response rate in treating rectal cancer patients. And when we observe patients who have a surgery where there's no tumor left there on pathology, it prompts the question of whether or not we could have indeed safely avoided surgery in that patient at all. And the answer is, I think, probably yes, but we'll get there. So total neoadjuvant therapy increases that observed path-CR rate. Remember, we talked along the way about path-CR rates ranging from like 10 to 15% when we were looking at traditional non-total neoadjuvant paradigms. But here we're getting a path-CR rate now to nearly 30%. So this is substantial. This is a lot of your patients. And these patients have a great prognosis. We know that path-CR portends a better prognosis. But if you think about this, putting yourself in the shoes of the patient, could this also actually be disappointing news in some ways, in that now you're recovering from a surgery that perhaps you didn't need, or recovering from trimodality therapy that perhaps you didn't need? So with total neoadjuvant treatment, I really think that's a driver in the broadening interest in non-operative management. Going back, just to again put ourselves in the patient's shoes, that Dutch study that we talked way back about at the beginning, and we talked about how radiation reduced local failure. What we didn't mention is that that study also showed some pretty impressive toxicity rates, not just of radiation, but also of TME itself. So we cause these patients some incontinence. And again, this bowel function evaluation here that you see, a little bit blurry, sorry, is in eligible patients. So these are patients at risk without a stoma. So patients who've had a TME or a TME plus RT. And we are seeing non-zero rates of incontinence at day, incontinence at night, anal mucus loss, anal blood loss, and use of pads. And having more than one therapy modality increases that. So it tells us that we really need to be mindful of trying to minimize the treatments that we are giving our patients, because we do have impacts on their quality of life, and not always positive in adding therapy modalities. So with that in mind, Haragama from Brazil is really quite a pioneer in this and has to be recognized. This is really where non-operative management started, at least in the mainstream. So way back in 2004, the Brazilian group started reporting their outcomes of non-operative management. And in this particular study, they reported 265 patients treated with pre-op chemoradiation as typical. And they found that 27% assessed at about 8 weeks after chemoradiation had a clinical complete response rate. So loss of visible disease by radiology and scope evaluation. Whereas 73%, of course, then had an incomplete response and went to surgery. So if we focus in on, among those, some had a PCR. Okay, fantastic. So if we focus in on those who had a clinical complete response versus those who had a path CR established on surgery, which we already know portends a really good prognosis, what do we see? We find that at a reasonable length of follow-up, local recurrence is minimally more in the clinical complete response rate compared to the PCR rate who've had surgery. Pelvic recurrence is not different. Distant metastasis actually appears better in the clinical complete response rate compared to the path CR, and same with 5-year OS. So these were really surprising data when they were first presented, and really controversial, made people angry, to be honest. But they kept at it, and again showed with updated data that, again, about 27% of patients had a CCR. Again, with even longer follow-up, they found that local recurrence after a CCR was relatively rare, and that in those patients who had local recurrence, salvage could be performed either surgically or, in one case, with brachytherapy, which is focal radiation treatment. Pelvic recurrences didn't occur, and distant metastasis and 5-year overall survival rates were pretty typical. So again, showing us that these patients seem to do pretty well, and we're at least not clearly putting patients at extreme risk in doing this. So they've updated their data since then a number of times. And there also have been some retrospective experiences elsewhere globally. And although not everybody shows the same CCR rate, and some of the global data show higher risks of regrowth, the salvage rate remains very, very high, even outside of the Brazilian data. And the overall survival and systemic recurrence rates also are very similar to what we've seen in historical data. So this is really encouraging and suggests that perhaps this can be done and can be done safely without, dooming these patients to worse recurrent disease, both systemically or regionally. So at WashU, we have been very interested in this as well. And in particular, recently reported outcomes of a prospective non-randomized single institution trial, relatively small, 19 patients. This study was giving short course radiation. So those other experiences I just showed primarily were with long course chemoradiation. So this, to our knowledge, was the first report of short course non-operative management. So our patients got short course followed by FOLFOX or CAPOX in the usual TNT fashion. And if they had a clinical complete response, they then underwent non-operative surveillance. And I'll touch in a minute on what that actually means. The primary endpoint of this study was clinical complete response rate. And secondary endpoints, of course, included safety profile as well as anal rectal function, because that's the goal of this potentially, is to improve anal rectal function. We excluded really high risk tumors, T4, or tumors far from the verge that are a little bit harder to assess in follow-up. And it was a decent spread of stages. We did allow some early stage low-lying tumors into this trial, although the majority had T3 or N1 disease. And what we found was that we had a clinical complete response rate of about 70%, not quite. And importantly, at 28 months median follow-up, so a couple years out, most of the patients, although not all, of those who'd had non-operative management, at least initially for clinical complete response, maintained it. About 1/3 of patients did have local tumor regrowth. As you can see, local tumor regrowth, in terms here, tumor regrowth free survival in blue, is very closely tailed by TME free survival, which makes perfect sense and is really what you should see if your patients with local tumor regrowth are salvageable. They should immediately then be going to TME, which is what our practice is. And you see that that's true here. So recurrence, when it occurred, was salvageable with TME. So you're not, again, kind of dooming any of these patients if you allow the potential risk for local tumor regrowth. On average, that happened about a year, just over a year after radiation completion, which I would point out, again, we use total neoadjuvant, so you have to factor in a little math here. Time after radiation completion, there's an additional 4 to 6 months of chemotherapy there, in this study, 4 months. So really, it's about 8 months or so after completion of all of total neoadjuvant treatment that most of these patients who have regrowth, at least in our experience, that occurs. In terms of how they did in other outcomes, in terms of 2-year disease-free survival, they actually had better 2-year DFS and OS, as well as distant metastasis-free survival than patients without a clinical complete response. So that's really good, and indicates that not only is it safe to do non-operative management and monitor these patients and salvage them if needed, if they have local regrowth, but actually they are still doing better than those patients who go directly to TME. We also found that having an uninvolved CRM on MRI at their original diagnosis was associated with higher likelihood of initial clinical complete response, which makes sense. Probably less bulky disease resulting in easier response. What we also found, which was really encouraging, was that rectal function by FACT-C score at 1 year was not different than at baseline entering into the study. So that's not to say we're getting them back to their perfect, 5 years prior to diagnosis function, but that at least their function is actually not getting any worse and holding steady from how it was when they presented. So up next at WashU is the NOM-ERA clinical trial. We're currently enrolling to this. It's a phase 2 multi-institutional trial. It's opening at Mayo and University of Colorado as well as in the Northeast. And that is looking at non-operative management using short course. Again, estimated enrollment here will be about 68 patients. It's short course followed by full FOX, then response assessment. Again, primary endpoints, clinical complete response. Secondary endpoints are as you would anticipate, with the addition of ctDNA correlates, which is kind of a nice forward-looking aspect. So what about the order of delivery? So should you give chemo first? Should you give radiation first? When you're doing TNT with the expectation of non-operative management, which is better? We have a little bit of information about what our order of delivery should be from the OPERA trial, although I will say that this is not published in full manuscript form yet. So as always, abstract results can change from time of meeting presentation before they're published. So big asterisks here. That said, it seems like a pretty clear answer to me. So this study was looking at patients with stage 2 to 3 distal rectal cancer, and the overall hypothesis that they had was that using total neoadjuvant therapy and selective non-operative management in those with a CCR would actually result in better 3-year DFS compared to standard of care trimodality approach historic data. So that's the overall hypothesis and the primary endpoint. Now, the study design gets a little interesting. Within that, they actually randomized to 2 types of total neoadjuvant therapy arms. So one was chemo first. The other one was long course chemoradiation first. And both arms, I should say, used long course here. And then they combined those arms together in order to make that overall overarching comparison to the historic control. So this is what that looks like. So they are enrolling their stage 2 to 3 patients. They randomize them either first getting chemoradiation or first getting chemo, then chemoradiation. Then they restage. And in this study, if they didn't have a complete response, they get a TME. If they do, they get watchful waiting or non-operative management. So what did we find in terms of what goes first? Again, until published, this is preliminary. However, chemoradiation prior to chemotherapy resulted in a resoundingly higher rate of TME-free survival, although it was not powered for this endpoint. What we can see here is that the initiation of chemoradiation prior to chemotherapy, as opposed to chemo first, improves that CCR rate. This is actually really not that surprising to me. It's really in keeping with all the other data that we've been talking about, where we have hammered home the fact that having some additional time after radiation for response is helpful in seeing that response, whether that's PCR or in this case, clinical complete response. This study was also updated at this year's ASCO. And an important thing to note, so of patients who got a clinical complete response in that trial, the 3-year likelihood of subsequently having regrowth or having a TME was about 21%. So that's fairly similar to what we've observed at WashU, which is that in whatever proportion of patients you get to a clinical complete response, there will be some who do have regrowth, and it's somewhere around a quarter or a third of those patients. That's also fairly similar to some of the other global retrospective data. However, even with the risk of regrowth being present, DFS and OS are best in the CCR group as opposed to a near CR group that they reported and an incomplete response group. So you can see that here. So you have better, not only organ preservation, obviously, if you're getting a CCR, but you have better DFS and TME-free survival, as well as overall survival. So this is really, really encouraging data and prompts further study of non-operative management, showing that not only is this safe, but actually these patients seem to continue to do as we would expect them to for having a good response, continue to do better than those who have incomplete response. In terms of what this actually looks like in practice, I'll give you this snapshot here. This is a handout that we actually use to give to our patients who have rectal cancer. But this is what that timeline of non-operative management looks like. It is not just watchful waiting in the sense of you're just waiting to see if something occurs. It is very much an active surveillance in the sense that we keep a very close eye on these patients. In the first 2 years after treatment, they're getting blood work, flex sig, pelvic MRI, and an appointment with a surgeon and an oncologist every 3 months. That is really important. In addition, we're imaging their chest and pelvis every 6 months. And then at a year, we're checking full colonoscopy. And then as they get further out, we back off on the timing of that. And that is because, like I mentioned for the normal R study, that highest risk of local regrowth appears to be within that first year and likely within the first 2 years following completion of therapy. So this is a very active program in the sense that you have to be all hands on deck. You need a team that is really dedicated and organized, and you need really great communication between your oncologists, your radiation oncologists, and your surgeons, because we're all going to be coordinating this care and be sharing images and making sure that these patients do not fall through the net. And if you have a patient where reliability is a sincere question, then this is perhaps not the best approach for them, and you have to keep that in mind as well. So overall, take homes for me, in my opinion, for non-operative management. Radiation before chemo in total neoadjuvant therapy will likely play out as improving response for non-operative management. That seems like a clear and obvious order choice there. Short course radiation appears to be able to be used in non-operative management with success. That's been our experience at WashU, and our rates of clinical complete response and longer term outcomes seem very similar as with long course non-operative management. While the order of treatment likely affects the clinical complete response rate, it does not seem like it's going to end up affecting the survival or distant metastasis rate. And we see that from the OPRA update. Now, again, long-term outcomes are pending, but we can at least say that the non-operative management groups are not faring worse. And as they frankly should be, in the sense of having a really excellent response up front, they appear to fare the best, which is exactly how we would expect. So not only does this appear safe, but it does, in fact, seem to be effective at preserving those good outcomes in those patients. That said, follow-up trials are absolutely underway, both at Sloan Kettering as well as WashU and other sites. So with that, I will wrap up my kind of structured part of this, and I'm happy to take any questions and try to provide any further answers too, and I'll stop sharing my screens.
Thank you, Dr. Henke, for an amazing talk and a great overview on a clearly very complex topic that you were able to make us be able to understand very simply. We have a lot of good questions here. Are you radiating T3N0 disease in the upper rectum, and how are you deciding on that? I think you might be muted, sorry.
Just realized that, thanks. Classic. So that's a really good question. And I would say that at WashU, our tendency is that if it falls within the rectum, we are radiating these patients, even if they are upper rectal cancers. Now, that is because as a paradigm at our institution, we do total neoadjuvant and do non-operative management as part of a large overarching prospective registry as well. So for us, the goal is not just the local recurrence reduction in terms of offering radiation in that setting, but also the possibility, even in some of those patients, to have non-operative management. Now, if you're at an institution that isn't doing non-operative management, then that's a really good question, in the sense that, again, the goal of radiation in that more traditional paradigm is to reduce the risk of local recurrence. And if you have a high rectal tumor that doesn't have a lot of low nodes or low pelvic involvement, then you can probably get that out, I'm hoping, all of you, at least after your fellowship, with a clean margin. And so the risk of local failure is lesser in those high rectal tumors. And so outside of a non-operative management paradigm, there may be less local recurrence reduction benefit from radiation in that setting.
Awesome, thank you. Another question, excellent talk. In the WashU study, were there any description of surgery difficulty in salvage TME surgery for the patients treated with watch and wait compared to TME after TNT?
Yeah, so there's really not a reduction in difficulty. I don't know how explicitly we described that. I don't think in really a whole lot of gritty detail, but the clinical complete responders, again, we're following them very closely. So the decision for moving to a TME surgery is at the first indication of local regrowth. And again, we're following these patients at 3-month intervals. So the second that scar stops looking white and clean and smooth, and a biopsy shows that there's recurrence, they're going to their TME. And so what we found is that those patients aren't, having more bulky disease or more challenging to resect disease than patients who, had an incomplete response to begin with. Now, if you lose somebody to follow up, that could potentially get more challenging.
Rishi, can I jump in for a second? We're fortunate to have Dr. Radhika Smith, who's a colorectal surgeon at WashU and has presented to this group twice already, which is, I think, a record. If she can just comment on the surgical aspect.
Yeah, Radhika, what do you think?
So I think, firstly, Lauren, that was an amazing talk. So thank you so much for your contributions to our fellows. But so I would say anecdotally, it seems like it is probably just like any other, like delayed radiated pelvis. You'll have some cases that are good and some cases that are bad, but the great news is that we have a prospective registry. We're just trying to accrue long-term follow-up and get enough patients, so eventually we will come out with our data looking exactly at positive margins, both distal and radial, and local recurrence. So we'll have sort of those pathologic markers that we look to as surgeons to really tell us what actually we're doing with regard to quality.
Thanks,
Thank you.
Radhika.
Thank you, Dr. Smith. And she actually had a question as well. Can you address the role of brachytherapy and proton therapy in rectal cancer in the current day?
Yeah, so those are also good questions. Brachytherapy, I would say most often ends up being in the setting of recurrent disease, although not always. Proton therapy, there are centers that use proton RT. Without going into too much detail of the physics of proton radiation, the long story short is that I can control the depth to which dose is delivered, and there's no exit dose with protons. So you can anticipate then that if you're treating a posterior area like the mesorectum, you're going to spare bladder, you'll spare prostate dose, you'll spare anterior small bowel dose, that type of thing. So really nice potential applications there in reirradiation, but also potentially long-term, we may find that there's some application there in upfront radiation, especially if you think about non-operative management as well, and the goal to reduce risks of longer-term toxicity impacts and improving quality of life outcomes. That said, there's not a whole lot of there's not really any randomized data for proton RT in the upfront setting at this point, but maybe down the line. For reirradiation, really nicely appealing because you're not dealing with kind of the stacking of dose to some of those normal structures. You're able to minimize that overlap with prior treatment.
And then can you talk a little bit about intraop radiation therapy and that role?
Yeah, so intraop radiation, that's not a program that we have at WashU, so my personal experience with it is relatively limited. But in patients where a margin is basically known to be high risk at the time of surgery, it's a really nice potential avenue for giving focal radiation dose right there in the OR where where your risk is. In terms of kind of mainstream overall comers, not a clear application right off the bat there.
Awesome. And then a couple questions regarding the non-operative management as to who follows these patients. Is it the surgeon, the med onc, or is it the rad onc? Who should be following these patients, and what are your thoughts on that?
Yeah, so I am I would say a hands-on radiation oncologist, and hopefully most of them out there are, but I like to follow my patients at Q 3-month intervals, especially in these non-operative management patients. I know our surgeons are as well because they're the ones scoping them. And most of our medical oncologists are too. The nice part is that we tend to have multimodality clinic days, not always, but frequently. So we can have a patient kind of skip between multiple office visits. I would say that the reason why I tend to follow these patients closely, at least right now, as our institutional experience is growing, and frankly, everybody's experience with non-op is growing, is that they can fall through the gaps. Despite careful management and careful work with nurse coordinators to follow these patients, there are sometimes patients that will pop onto my schedule, and I look and I see, they're not scheduled yet with surgery for the scope that they're supposed to be having at this same time. And so we are all a safety net for each other in making sure that we keep track of these patients.
And then any pushback from insurance companies regarding the frequency for surveillance for the watch and wait patients?
Short answer, yes. Longer answer, there's pushback from insurance companies for surveillance in just about everything. When I frame it to insurance companies, when you are dealing with somebody who's non-operative management, there's often still some question and scarring and thickening that perhaps you can play off of as being indeterminate if there's a CT. And that's frankly true. We know that MR is better for looking in that area, and there's certainly going to be some post-treatment fibrotic change happening. And then also you think of it in a sense is almost being like restaging each time. If you're seeing that, you're making sure that they're still in a CCR pattern. And so I haven't had too much trouble for it, but certainly as with insurance everywhere, you can run into some hangups.
Sure. And then one final question. Many institutions still prefer to perform surgery within 1 week of short course RT. Any comments regarding this continued practice?
Yeah, so that's been a really long historic paradigm. So as with anything, change is challenging and slow to come sometimes. I think Stockholm 3 fairly convincingly shows us that there is a higher rate of postoperative complications with immediate surgery versus delayed. That said, there is another side to that sword. With short course radiation with delay, there's actually in that same Stockholm study, about a 6% rate of admission for RT-related complication. So it may be that there's a little bit of a wash there in terms of some of that acute toxicity. I prefer to do short course with delay, but there are scenarios I should point out in which case short course and immediate surgery might actually be the preferred route. You got to keep in mind scenarios like settings of high-risk patients. If somebody has history of UC or some inactive Crohn's or other types of scenarios where you're really needing in that case to be able to do preoperative RT, but not wanting to wait for worsened RT related complications. Setting of prior prostate brachytherapy, that's a really nice reason to do short course radiation. You don't have to worry about the cumulative rectum dose. And then another thing to think about is that the whole benefit, apart from tox reduction of short course with delay, is that you have a higher path CR rate. But there are sometimes patients who have, let's say, T2 disease and a questionable lymph node or two, where you would actually really love to have that path information to be able to decide whether or not you want to commit them to 4 to 6 months of chemotherapy. A lady, for example, that had T2 questionable, maybe N1 disease, and was a concert pianist, didn't really want to have to get chemotherapy. She didn't have to. So we, in that case, did immediate surgery so that we could not burn bridges and get stuck doing post-op RT if that node was real, but also be able to know for certain if it was real to choose about chemo and the risk of neuropathy. So there's always a little bit of nuance to everything that we do. I would say that short course with delay should be emerging as the standard of care after Stockholm, but there are caveats to that too.
Thank you again, Dr. Henke, for an amazing talk and sharing your expertise with us. This was very well attended tonight and got a lot of interest and buzz, and so we are thankful for your time and your expertise again. So we also want to be respectful of your time as well. So with that, we're a little past 7 o'clock. So we'll end there unless there's any last minute questions. So.
No problem. Thank you all. Have a good one.
Yeah.